Hello, everyone. Welcome to MedCity's Invest Pop Health Conference and our final session on startup pitching. So my name is Orudhuti Parmar. I'm the editor-in-chief of MedCity News. Before we begin the contest, I wanted to share a few things about MedCity News. So again, like I mentioned, my name is Orudhuti Parmar. I'm the editor-in-chief and I've been so since July 2016. The company was founded in late 2008 to cover innovation in healthcare. We are a national publication drawing nearly 2 million page views and 500,000 unique page views per month. We cover biopharma, digital health, medical devices, diagnostics, as well as hospitals and payers in the context of the industry's overall transformation. And needless to say, we're covering COVID-19 as well. We host conferences focusing on investment, population health, precision medicine, digital health, and patient engagement. We also accept outside content through our influencers program. We have another program called MedCitizens, which is a membership-based program for startups with editorial and event benefits. And Stephanie Baum, our director of special projects, leads that. And her email address will be put in the chat in case any of you wanted to join. We also started hosting the MedCity Pivot podcast a few months ago to sort of encapsulate the pivot that all of us are experiencing in our business lives as well. So you can listen to all our episodes here. And if any of you have any suggestions for an outstanding speaker, please do email me at aparmar@medcitynews.com. So a big thank you to our partner, New Orleans Business Alliance. This is the second year in a row that we're doing this conference with them. Last year, we were actually in NOLA and enjoyed the weather and the food. So this year, unfortunately, we are all stuck in this virtual world for some time. So I wanted to hand the microphone over to Jeanette Wieland. She's the VP of Bio Innovation and Special Projects. Jeanette, take it away.
Thank you, Arundhati. I appreciate that. On behalf of the New Orleans Business Alliance, I want to say that we really value the partnership with MedCity News. I think you guys do an excellent job. And I've been watching the past couple of days, and the content's been very impactful, and it's been very candid. And we appreciate that in New Orleans. I think our city is a best kept secret on the digital health and biotech scene. And we appreciate the partnership and bringing attention to our city and showcasing the talent that we have here. Today, I'm really looking forward to watching, speaking of talents, watching this pitch competition and understanding more and learning more about the investment opportunities and the technology that the entrepreneurs featured here today are going to present. And hopefully they're going to be very impactful and implementable solutions. So thanks again, and I will enjoy the show.
Thank you so much, Jeanette. Like I say to other people, we are sort of a mutual admiration society here. We also wanted to thank our sponsor, Merck, without who this event would not be possible. Some of you may have seen our session a couple of days ago where we discussed social determinants of health. And the gentleman leading social determinants and policy for Merck joined us. That video will be made available soon to all our registrants. So here are the contest ground rules. We have 6 startups today. Each startup has 10 minutes, 4 minutes to pitch, 6 minutes with a Q&A with the judges. Time will be enforced strictly. At the end of the 5 presentations, we will do a quick online poll to determine an audience favorite from today's track. And the winner will be announced at the networking reception soon after the event closes here. Here are our esteemed judges: Ian Chang, principal of Flair Capital Partners; Robert Tucci, managing director of the Texas Halo Fund; and Brandon Finney, senior associate of Providence Ventures. A little more in detail about each of our judges. So Ian Chang is principal on the investment team at Flair Capital Partners. Prior to joining Flair Capital, Ian served as a senior vice president and a founding member of Care Allies, Cigna's family of multi-payer provider services, population health management, and home-based care business. In that capacity, he was responsible for developing new technology-enabled services, evolving existing solution and service lines, and providing ongoing product management across Care Allies businesses. In addition, he was also responsible for developing inorganic strategies for Care Allies since its inception. Before launching Care Allies, Ian held a leadership position with Cigna's US Strategic Operations team. Welcome, Ian. Next, we have Robert Tucci. He is a managing director of the Texas Halo Fund, an active personal investor and formerly chair life sciences at the Houston Angel Network for 5 years. Rob oversees THF's national life science investment portfolio, as well as supporting the rapidly growing Houston life science ecosystem. He's a regular judge, panelist, and speaker for various university and venture capital events. He's the founder of Yardley Group, an active chemical development and export business serving the mining industry in South America. Rob serves on the board of directors of Adient Medical and as a board observer with other startup life science companies. Rob holds degrees in chemistry and business and resides in Houston with his physician wife. Welcome, Robert. Brandon joined Providence Ventures as a senior associate in 2019. Prior to PV, Brandon worked at Transformation Capital, a Boston-based growth equity firm focused on healthcare IT and tech-enabled healthcare services while pursuing an MBA in Wharton. During this period, Brandon spent most of his time in an investor role at Strathspey Crown, a Newport Beach, California-based investment firm that made a wide range of investments across healthcare. Brandon also spent time at ShoutStore, an early-stage e-commerce platform for physician practices and portfolio company of Strathspey Crown, where he led corporate development efforts. Brandon holds an MBA from the Wharton School and a degree in mathematics from Northwestern University, where he was a Ryan Scholar. Welcome, Brandon. And these are our pitch perfect finalists for today: Pix Health, Phox Health, Paired Team, Dina, Happy, and Pac Health. So we will begin with Pac Health. Pac Health delivers digital health coaching to manage 25 plus chronic conditions, behavioral health, and social determinants of health needs. Connecting with members weekly via phone, text, and email, Pac Health's engagement is highly personalized to deliver tailored education, accountability, and resource coordination based on each individual's goals and barriers. Pac Health serves customers across health plan, employer, pharma, health system, and nonprofit verticals. Mary Beth Basu, account executive, is our first presenter. Take it away, Mary Beth.
Thank you. I'm happy to be here.
And your time starts now.
Good afternoon. I'm Mary Beth Basu. Pac Health is excited to be here today. Since 2014, we have been impacting chronic conditions, behavioral health, and social determinants of health, one person at a time, through our efficient and scalable solution. Our CEO, Mazi, founded Pac Health to really change the way we approach disease management, bringing together experts in patient care, coaching, content, business, and technology. We put the patient first and designed our approach on what each individual needs to be successful. Most disease management companies focus heavy on education or fancy portals and apps. We have found patients don't really want either. They see their doctor regularly and they know what they should be doing. They just can't seem to do it on their own, often due to inherent barriers in their life. And that's where we come in. Pac Health believes you can't treat chronic conditions in a silo. You have to understand what else a member is dealing with: multiple comorbidities to manage, behavioral health issues influencing daily behavior, needs around food insecurity, transportation, or affording prescriptions. And you have to be able to address all of these in an empathetic and an actionable way. At the heart of our program are certified health advisors who use a secure operating system built on Salesforce to serve up just the right resources at the right time to our members. Our service partners include Uber Health, Aunt Bertha, Needy Meds, National Food Distributors, and more. It's a highly customizable platform that allows us to white label, configure escalation protocols for our different partners, and deliver relevant resources to members simply through text, email, and phone call, just like you talk to your friends. We coach on more than 25 different chronic conditions, and with each individual we engage, we also address behavioral health and socioeconomic needs. Our health advisors reach out to members 5 times a week. That's near daily contact to work on smart goal setting, tracking, and overcoming barriers as it relates to compliance and lifestyle improvement. We complement clinical care, we don't replace it. Week to week, we collect validated patient-reported outcomes as well as data from hundreds of remote monitoring devices to demonstrate improved outcomes. We are NCQA accredited for population health management, and we've doubled our staff and revenue over the past year in the midst of a pandemic. We offer several pricing models, including per engaged member per year, per member per month, and we even have our own NPI number, so we can bill through the claims system for our employer and health plan partners. We do work across several verticals. Each of these areas struggles with the same problem. How do you drive better compliance and behavior change in patients at home between doctor visits? Some examples of our partnerships include white label programs for Novo Nordisk in diabetes and for American Cancer Society in oncology. We have about 20 employer clients, mostly self-funded. And in terms of health plan partners with United Healthcare and Blue Cross Blue Shield of North Carolina, we focus on Medicaid, Medicare, and commercial segments with a food as medicine approach, where we ship healthy food boxes directly to members' homes and couple that with coaching. And with Humana, we focus on members with comorbid behavioral health and chronic conditions. Across verticals, our program is quite effective. First, people like the program and they stick with it. It's no secret that you can't drive results with poor engagement. As we help members overcome barriers and accomplish small weekly goals, we see improvements over just 3 months in clinical indicators like a 1-point average A1C reduction, 44% reduction in pain, reduced admissions, and a 54% improvement in medication adherence. Behavioral health improvements like reduced depression and anxiety and weight loss. ROI for our program has been shown nearly 5 to 1 by third-party analyses based on reduced claim spend. So by designing our program to serve the members' needs first, keeping it simple and efficient, and really focused on delivering services, care coordination, and accountability that each individual needs, we also serve our clients' needs for better population health management as well.
Time's up. We're going to go first to Ian, then to Robert, and then to Brandon for questions.
2 questions. Can you share what's your business model? What's your pricing model? And then also how is Pac Health differentiated from some of the health plans? Like for example, Cigna has its own consumer health engagement team and care coordinator team.
Yeah, absolutely. Our pricing is offered in a variety of models, depending which vertical we're working in and really what the client's looking for. So the roundest figure I could give you is that per engaged member per year, and that's $425 flat cost there. It's interesting that you bring up that some health plans have their own disease management programs. With one of our health plan partners, Blue Cross Blue Shield of Alabama, they offer sort of a bare bones disease management at no cost to their groups, but they have many self-funded customers who really aren't satisfied with the level of touch they deliver nor the outcomes. And so they offer us to that same self-funded employer group population as a buy-up option with better breadth and depth of services, as well as stronger outcomes. In other areas, we find that health plans have a strong case management team, and while they may have nurse support in place to speak to members' chronic condition needs, most of the members that we engage with, they really don't need clinical advice. They understand what they should be doing. They really need more subclinical assistance around those socioeconomic needs and daily behavior change. So our health plan partners really appreciate how we can complement their care teams. And in fact, we build escalation protocols to refer members back to those nurse case managers when it's most appropriate.
Thank you.
Go ahead, Robert.
I guess I'm up next here. So
Hi, Rob.
Hello. First off, excellent presentation. I think 4 minutes is a tough bar, and I think you did really well.
Thank you.
Cramming an awful lot into 4 minutes. I would like to understand. I have 2 aspects of my questioning. One is telemedicine versus in person. How much of this is online, virtual versus in person? And then secondly, how do you confirm compliance? People can game the system left and right, and much of the return on investment, the ROI that you pitched, is based on a reduction in claims. So I guess that's real, but still, you still must be calculating compliance in some way. So if you could address telemedicine versus in person, and then also compliance.
Yeah, absolutely. To take your first question, none of our interaction is face-to-face. We interact completely digitally with members. About half of the total touch points take place over text. We find that that's what people prefer. We do one weekly phone call that's very focused on the member's SMART goal for that week, as well as ways we can assist with targeted pieces of education or referrals or care coordination. And then the email is usually once per week. We typically use those as a way to collect some data in between the phone calls. We like to keep our phone calls very short, like 13 minutes on average each week. So collecting some data using an email survey is a good way to do that. In terms of adherence and compliance data, we use these patient-reported outcome sets to gauge symptoms, severity, behaviors, and we ask these questions at the beginning of the engagement and then at about the 3-month point. So we've had the opportunity with some of our health plan partners to compare what patients report to us with what our health plans actually see come across the claims, and like lab data, for example. And we've had a 93% positive correlation between what members have reported to us and what comes across. So that leads us to believe that members have no need to lie to us about their daily behaviors. We don't report individual information back to their plan, and we're open about that. So early in the engagement, we help the member understand that this is really there to benefit them. We don't drive the conversation or dictate where the member sets their goal. We want that all to be really driven by the member, so that it's a very individually focused program, and there for their needs.
Okay. Do I have time for one more question, or did we move on?
Robert, can we come back? I just wanted to get
that's
Brandon in.
That's perfect.
Go ahead, Brandon.
Oh, here we go. So this is more of I guess, an execution question, well, questions and that are related, hopefully, is one, what's your current client mix across life sciences, employers, health plans, and providers? And then secondly, with such a broad and holistic offering, how do you navigate the sales cycle or sales process and making sure you're selling to the right department or to the right stakeholder, since you have these siloed departments, especially in the provider setting, that are measuring different disease states, unless you're talking about a centralized pop health department. But how do you think about navigating that and selling such a holistic and broad offering?
It differs a lot depending, from plan
Sure.
to plan. We'll have very different teams in the room. It often begins from a product and innovation standpoint, where teams are looking for ways to improve on the current service they're offering. So they may realize, for example, like I was mentioning earlier, that they have real gaps in their ability to manage chronic conditions. Other times it'll be vertical specific. So a plan's Medicare Advantage team, for example, might come to us. In those cases, we'll usually start with one segment of membership in a test and learn capacity. And then as we prove our results, the plan will broaden us out to additional sectors. And then in terms of the breakdown, I would say it's probably about 40% life science, 30% health plans, and then 30% employer.
Thank you.
You're welcome. Do we have time for Rob's final question?
Yes, I'll give Rob some time for his final
Okay, well, this is a pretty quick question. What are your top 5 diseases that you manage?
Diabetes, prediabetes, weight management, oncology, and autoimmune.
Thank you.
You're welcome. We find the average person we engage has about 3 chronic conditions.
Great. Thank you so much, Mary, for that. We'll keep moving on. So our next presenter is from Happy. Happy was created to ensure that every person at every time of day and night feels heard, understood, comforted, encouraged, and important. Jeremy Fishbach, CEO and co-founder, will be our next presenter. Before we go to Jeremy, I wanted to mention that every startup's executive summary will be placed in the chat the moment they begin speaking. So whoever wants to check out their executive summary are welcome to do so. So Jeremy, I'm going to stop sharing and go straight to you.
Okay. Can you hear me?
Can hear you fine.
Okay. Welcome. Yeah. Okay. So can you see the screen share?
We can see the screen share, and I'm going to say that your time starts now.
Okay, so thank you for this opportunity. So Happy is a 24/7 emotional support platform that scalably addresses social isolation, loneliness, and actually a wide range of behavioral health issues. You're all going to be familiar now with this epidemic of loneliness and isolation, which long preceded COVID-19. Half the country doesn't have anyone who meaningfully supports them. And another sad 50% stat is that people are 50% less likely to die if they have strong social bonds compared to people who don't. Loneliness, as the prior Surgeon General has said, is as deadly as smoking almost a pack of cigarettes a day. And obviously this has a huge impact on healthcare costs. This wouldn't be a problem if there were abundant resources in the peer-to-peer mental health space. There aren't. Most resources are focused on more serious mental health issues and are more costly and stigmatized. So what is Happy trying to do? We actually define the problem really as a epidemic disintegration of primary support systems of family and friends, and we help people build new ones through both a national network of highly qualified and compassionate peers, and also a tech platform that allows people to connect, reconnect, and build ongoing relationships with our peers, and in short, go from having zero primary support system to a dream primary support system comprised of 5 or 10 exceptionally compassionate peers who are available around the clock to support them at a very low cost. A word on our support giver network. We've redefined in many ways what peer support can look like. We have one of the most selective and also scalable models for peer support. I'm sure we'll get into more in the FAQs, but in brief, all of our support givers have a healthcare background and community health, peer support, and also have to pass very rigorous tests for their ability to provide the essential ingredient of emotional support of mental health effectively, which is emotional support. Our tech, I'll just say, is more than an app. We do have a D2C app, which is basically Skype meets Uber instant voice-to-voice communication with hundreds of matching algorithms that help us not just instantly, but intelligently route calls between our callers and our support givers. We're now contracted with Centene Wellcare, and there we're doing inbound and outbound calls, toll-free, and have a whole data and analytics infrastructure that's dynamically sharing insights with their care management team. As you can tell already, Happy is both human and tech. So we know that compared to text-only services, tech platforms that actually have a human component show significantly better outcomes in driving behavioral change. We see that after thousands of calls, we have an average reported improvement in mood of around 45% and an average decrease in anxiety of close to 50%. I'll sum up all these slides by just saying, most notably, we launched 3 months ago with Centene Wellcare, the largest Medicaid plan in the country, in their largest market, Florida, as a way of helping them with their COVID-19 release, just their COVID-19 response, rather. That plan has grown to 2.5 million members. And after 3 months into a pilot, they're already extending this into a much larger contract over a much longer period of time. They've started to make introductions to other plans. And basically what we're doing with them is emotionally supporting their members. We're conducting mental health assessments. We're also in discussions with the state of Florida, who is very interested in mental health assessments. Oh, we at time?
We are at time.
Okay, I'm sorry. Okay.
No problem. Robert, why don't you go first, and then Brandon, and then Ian.
Sure. Certainly in the times of COVID that we are right now, there's a huge need for this. There's simply no question in my mind. But how transient will this demand be for your service once we have vaccines, once we quote unquote return to normal, once COVID is in the rearview mirror?
Yeah, I mean, we were in procurement with Centene, WellCare, United Health, and other payers before there was any COVID. This epidemic of isolation, loneliness, and really disintegrations of primary support systems long preceded COVID, and unfortunately, every trend line points to that continuing. So we don't see it as being transient. We think that this is exacerbated problems, but yeah, with or without a vaccine, this will continue.
So my second question, you quoted some statistics, a 45% improvement in mood and 50% improvement in something else. I just wondered how do you quantify that?
Yeah, we do pre and post call surveys of callers with other partners as well, American Heart Association, American Nurses Association. So these are reports from users. This isn't a clinical trial, but yeah, we gather a lot of data that our users seem very happy to share pre and post call.
Thank you.
Let's go to Brandon.
Oh, lots of questions. Trying to prioritize here. First, with your mention of Centene and WellCare, is your go-to-market strategy to focus on payer contracting, or are you going to also include direct-to-consumer and provider relationships?
Yeah, it's a good question. So we've signed our first, and now soon are about to sign our second health system customer. That's actually happy as a resource for staff, an employee benefit from burned out healthcare workers. So I will say our primary growth strategy is payers. My partner is a former national head of innovation at Aetna Medicaid, and from the beginning, we've never wanted to just be D2C. The app is available D2C. We think we have some interesting ideas there, but I would say payers at the top, health systems next, and then senior space after that. We just signed our first large conglomerate of assisted living and senior living facilities in New Jersey, and we see that as being a big opportunity as well.
Makes sense. And one last question. So with the payer go-to-market route, historically and still, I mean, behavioral health has been a neglected area of healthcare. And with the payer standpoint, I mean, they're reluctant to invest in behavioral health benefits for lower acuity patients that don't have comorbidities because there's not a clear medical utilization benefit from a ROI standpoint. So from Centene and WellCare's perspective, since you are targeting, from my understanding, lower acuity patients that don't necessarily have comorbid conditions that give you that clear attributable ROI, what is the selling point for, say, Centene in this example? Well, what's the main value prop that allowed you to win such a great contract?
So first of all, we're only supporting patients now who have a prior behavioral health diagnosis. So it's not simply isolation and loneliness. I mean, number one, it's to just allow them to manage the plan. They've gone from 800,000 to 2.5 million members in the last year or so. They simply can't do it. So Happy is basically a turnkey add-on to the beginning of the continuum of care. It's very easy for them to roll out. It increases member engagement significantly. We thought we were going to hit 100 members. We're going to be hitting tens of thousands. We're conducting mental health assessments that are contractually obligated by the state. We're doing referrals that help just detect issues early on, social determinants, mental health referrals. So there's actually a lot of things. And then there's obviously just the main thesis, which is that people are seeking this exact support in really expensive ways, ED visits, primary care visits, psychiatry visits. And so they believe after a certain period of time, even though this isn't their focus, just over time, we will see an ROI just in that respect. But they're looking at a much bigger ROI, which is just winning contracts. And they're having a hard time even maintaining the contract they have with their resources. So I would say
employer contracts or
just contracts with the state. I mean, they have,
the state.
They have, as you know, just a lot of contractual obligations that they're having a hard time meeting. So I think that there's a lot at stake for them.
Thank you.
Thank you.
Jeremy, thanks so much for the presentation. So want to drill down on the attribution of the cost avoidance. You mentioned a number of things like downstream ER avoidance and others. like how, from your conversation with Centene and WellCare, how do you attribute the downstream cost savings accurately back to Happy versus some of the, I'm sure they also offer many of the other benefits as well as solutions to the same members.
Yeah, I mean, that's a great question. I mean, first of all, we'll have a better sense in we've only been at it for 3 months, so they're extending our contract. That's encouraging. It'll probably take 6 months or a year, but we went into this with a specific population of now, 35, 40,000 people. There will be a population of 35 or 40,000 people who have not received Happy. So you're right. I mean, this is why we don't do value-based contracts. My partner has from the beginning pushed for just monthly subscription rates. I mean, from our partners, it could be anywhere from $2,000 to $10,000 a month, depending on the volume of calls we're doing. But we're also just a lot more focused on becoming sort of entrenched in their workflow and just as part of their behavioral health network, so that I mean, a lot of things, as you know, don't have an ROI. Care management doesn't have an ROI. I think that they just see us as a necessary addition to their plan through COVID and beyond. But yeah, I mean, just the way we're setting it up, we will be able to take with their Med Econ team a look at the tens of thousands of people who we have touched and the people who haven't, and see what happens. A lot of things we're doing will increase utilization, right? Because we're actually referring people in to use services that they're supposed to be using and to this point haven't. We may be involved in their vaccine rollout too. So I think that there's it's going to be complicated, but yeah, we certainly anticipate that people who are using this service will be less likely to use more expensive alternatives that are more costly and just uncomfortable.
Got it. And maybe one last question. You mentioned about the pricing model. Based on your slide number 8, it seems like you are charging a fairly low PMPM. I don't know if that's just from the pilot discounted pricing. Can you talk about that in some, just even if you don't go into detail, how you're going to price this in the long term?
Yeah, I mean, it's a good question. I mean, number one, with D2C, the pricing is $24 an hour. We pay support givers $15. So as we export that model to the payer space, I mean, the first thing is just pricing it at a point where the payer will say yes. So initially that was, I'll say we were undervaluing the service. Now it's going to be at a point where we've got a 20 or 30% margin, and it's all basically comes back to a $15 an hour or $15, $16, $17 an hour direct operational cost for us. But I think in the payer space, the overall margin is going to go from 20, 30% to closer to 50%, and it'll depend on the payer. It'll depend on the leverage we have, but even now, that's what we've been able to work out with them.
Thanks.
Thanks,
Thank
Dina.
you so much, Jeremy.
Thank you.
Next up, we have Pair Team. Pair Team is an operational platform and care team meant to automate value-based population health. The platform monitors health plan and system data to trigger automated workflows that engage patients to schedule clinically impactful visits, surface care recommendations to clinicians, and manage follow-up care coordination. For practices, this drastically improves care quality and visit efficiency. For plans, this aligns day-to-day operations with total cost of care. For patients, this improves health outcomes and relationships with their health providers. Neil Batlivala, co-founder and CEO, will present next. For the Q&A with the judges, Neil will be joined by Cassie Choi, COO of the company. Take it away, Neil.
Hi, everybody. Alrighty, let me share my screen here. Thank you so much for giving us this opportunity. Hi, everyone. We're Pair Team, and we put value-based care on autopilot. Managed care is continuing to grow as the future of the health industry, primarily driven by an urgent need to control costs. 70% of Medicaid and 35% of Medicare beneficiaries belong to a managed care plan, and entrepreneurs have taken note, building organizations like Oak Street, Iora, and CityBlock. But despite sizable investments, these tech-enabled organizations manage less than 1% of managed care patients. The truth is, existing clinics are drastically underserved to succeed in managed care without the core operational tools available to their tech-enabled counterparts. The two primary challenges are cost and operational disruption. Transformation involves significant technology investment, hiring, and may take months to years where the clinic is at existential risk. Pair Team is the operational infrastructure to instantly transform your practice and succeed in population health management. We bolt directly onto practices and act as an extension of their care team to make meaningful care improvements on day one. We don't just provide data, we operationalize it. Our model is unique as an end-to-end operations platform backed by a care team to combine the scalability of automation with the human touch to build meaningful patient relationships. We automate across the spectrum of front, mid, and back office work, including text-based outreach, form management, care coordination, and documentation support. Ultimately, we modernize clinics, build patient trust, and prioritize interventions to manage total cost of care. And this is a massive market. Looking at just the non-clinical spend in primary care, we have $52 billion, and the managed care market is upwards of $500 billion across Medicare and Medicaid. And this market continues to grow with an aging population and the COVID-induced economic downturn. We're the right team to do this because we've done this before. Cassie and I met at Forward 5 years ago, where we built a comprehensive care platform for hundreds of care coordinators. We built a powerful, high-touch, consumer-friendly workflow platform driven by deep patient data sets. We know this solution inside and out. Paul Cohen, former strategy executive at One Medical and now COO at Galileo Health, is a key advisor along our journey. On top of this, we have a unique go-to-market through Medicaid, typically overlooked by other healthcare vendors due to lower reimbursements and complex patient engagement. This creates a massive white space in the market as unemployment and enrollment continue to rise at staggering rates. CMS is desperate for population health solutions. Lastly, there are overlooked network effects within states as providers belong to tight-knit communities sharing a mission of providing care for underserved communities.
1 minute.
Proving value for one clinic opens the door to neighboring clinics. And this is not hypothetical. We are seeing strong initial results with the Medi-Cal population over the last 3 months. Working with 2,000 patients across 2 clinics, we've tripled preventative visits and increased baseline revenue by 15% in 2020, all under the shadow of COVID. Projected into 2021, this is expected to increase to 40% increase in revenue. And for us, this means a net annual contract value of $25,000 to $50,000 per clinic using a simple revenue share model. Our model is expected to evolve as we expand into the market. By building concrete evidence for improved outcomes with independent clinics, we plan to expand into parent IPAs and ACOs and even managed care plans as a provider enablement solution, moving our revenue share model to a direct capitation model. Healthcare is local, and we expect that true scale and impact will come from solutions that enable existing clinics to modernize their infrastructure. Thank you.
That was perfect.
Perfect.
We'll first go to Brandon and then to Ian and Robert.
Perfect. Thank you, Neil. And this is a hot area for us, being a strategic fund for the Providence system. But just so I understand the nature of the solution, you're targeting private practices and acting as kind of like an ERP infrastructural backbone to streamline operations? Is that it? Or are you trying to actually assist the transition to value-based contracts?
So if the closest complement is something like Aledade, which is helping to assist in that transformation, where they provide a lot of data and consultation services, we believe they stop one level short. And we actually operationalize it, doing the patient engagement on their behalf and working with prioritizing visits for that practice, really using the provider's schedule as that mechanism. So we directly engage with patients. It's almost like a tech-enabled MSO.
Got it. And are these, are you actively trying to help providers actually acquire value-based contracts and move away from fee-for-service as far as percent of patients?
We haven't gotten that far. So we're actually in step 1 of this. Step 1 is just proving outcomes. So we are working with the clinics right now and just showing hey, working with us, you're going to increase clinical revenue based on quality incentive programs and have clear case studies. And that's what we're doing. That's kind of what the focus is. But yes, we hope to work with providers just like CityBlock out in New York to help enable, build the payer provider relations for value-based contracts. In fact, we want to say working with us gives, de-risks the contract for the payer.
Got it. Well, and one last question now that I understand. Can you give one or two case studies of actual use cases that you're attacking and directly addressing to provide that kind of operational lift?
Yeah,
sure. CityBlock.
Cassie,
So the clinic that we're working with today, their quality score was a flat 0. And in 3 months, we've actually brought it up to, it's not crazy, but we brought it up to 0.5 today in 3 months. By the end of the year, it'll be at 0.75, which is $18K just for the year on their bonus PMPMs, which is significant in a value-based contract for them where they're struggling. And talking to their IPA, they know that this is a problem clinic under the shadows of COVID. And so being able to build this case study for value-based contracts is pretty significant and gives them an onus to say we can take on more members and really boost our programs without bringing on more staff. They actually had to lay off a lot of their staff. And so we're a much more sustainable way to have a quality program.
Yeah, that is the 15% increase in baseline revenue because these are Medicaid patients. So you're talking, not a lot of dollars in the beginning. So that's meaningful for them. 15% improvement across just quality scores.
Got it. Thank you.
Thanks so much for the presentation. So you mentioned Alidate. So Alidate, of course, it's a wholly tech plus services enablement platform. And having come from a business similar to like in value-based care enablement, a lot of the needs are about the people, like even staffing the embedded care coordinator to drive a lot of these kind of outreach, engagement, and workflow. Like, do you guys offer services as part of the solution where you just provide the technology so that you can help providers better utilize their existing resources?
So what's really great about us is we are the care team. And because we build the technology and we can evolve that technology very quickly, we can train our own care team to be using those tools very rapidly. Whereas Alidate faces this problem of culture adaptation within each clinic. And so within each clinic, you have to not only help the physicians really adopt a culture of quality, but within our team understands the goals of each clinic and how to use our tools to optimize for outcomes. And so we can always be optimizing for our tools and for outcomes at every given moment. And so we just bolt on. Our care team reaches out to our patients. They schedule directly into the EMR, so no integrations required. And we can just work with the clinics that we're working with. We give the physician tools. And so we're a part of their team. The patients that we're reaching out to think of us as someone just sitting in the back office of their clinic. They never know us as care team, but we're the much more cost-effective care team that these clinics could never hire on their own, with the added benefit of automation and technology that they never have to train their on-site staff to use.
Got it. So you rebadge your staff and then to be part of the clinical care team. And
it's largely there though.
Got it. And how do you guys select the potential customer? Because knowing that you are rebadging or staffing your own team, like how do you manage the capacity if there's not enough of a value-based contract lives under management to justify this kind of investment?
Yeah, so we are actively doing demand forecasting, right? With 2,000 Medi-Cal patients, that'll mature over time. I think the key here is that we can definitively do it more cost effectively than this Medicaid. So as long as we're bringing in more dollars into that clinic with their quality incentive programs, we're in a good spot. We have, a baseline of about 45% operating margins, just based off of, past experience and what you can point to S1s of One Medical and Oak Street of what a full stack provider's operating margins are at 35%. I will add one piece. We really focus on core activities to lower cost of care. These are annual wellness exams, ED discharge follow-ups, transitional care management, and enrollment into long-term support services. We know actuarially that those focusing on those things, basically prioritizing clinically impactful visits for the physician, is going to lower hospital utilization.
And the key things for that is that they're mostly administrative, and our platform, our technology platform that we've built out, automates a lot of that work and ensures that no balls are dropped along the way, which takes a lot of the thought process out of that work, and ensures that our team is highly efficient in doing that work, which reduces costs of us administering that work for our clients.
Got it. Thank you. I have more questions, but I may follow offline.
I love it. Yeah.
Let's go to Robert.
Well, thank you very much. It was a very good presentation, and I've learned quite a bit. So just to understand your marketing, the way you've described it is really kind of a white label. Is that correct? You're really transparent to the patient. Is that correct?
Yeah.
Exactly.
Okay. And how would you, with regards to the practices, you're really addressing standalone practices? Did I understand that correctly?
These independent clinics, but there are needs in the same way that a IPA or ACO would hire an MSO.
Sure.
In that same way, we work with their independent network and clinics of that network.
What would be your breakdown between, say, primary care and specialists or something like that?
We exclusively work with primary care right now.
Primary care.
That's just the focus right now. Yeah.
The interesting way that we work with specialists is by way of referrals. And so some of the care gaps that we address are, for example, breast and cervical cancer and colon cancer screenings. And so when a primary care physician that we work with orders one of those referrals through our platform during the visit, that comes to our care team to coordinate that care with our patient population. And so they get a text message from us to say, your physician ordered a mammogram, and we're here to help coordinate that care. We've sent the referral to this imaging facility. We're here to help you schedule that appointment. And we make sure that that appointment actually happens. The care gap doesn't get closed unless they actually attend that appointment. And we know with social determinants of health, these patients face multiple barriers of accessing that appointment. And so we're here to break down those barriers with high touch care.
Fair enough. Well, just to understand a little bit further also about the sector, there are competitors that you have. And do I understand correctly that the way you differentiate your product is both by online, but also in person, telephone calls are related? Could you discuss how you differentiate to a higher degree?
Yeah, we have an algorithmic workflow such that first we automate outbound text messages to patients. 40% of our patients do convert to a scheduled appointment via text message. And so we have really great engagement through text message and email with our patients. But when patients don't respond to that, we escalate to phone calls. And a lot of our patients do prefer to talk to us over the phone. And we have bilingual care navigators that schedule appointments over the phone. And so we track that through our CRM. If a patient responded to a phone call to schedule their appointment, when we're scheduling their mammogram, we just reach out to and call them. We also track when they want to talk. If they are somebody that works, in the morning, we're going to call them again in the afternoon for that. So our platform really takes into account relationships and time of day to call them to not only minimize our costs of delivering that care, but also really for engagement.
In terms of just differentiation, to kind of go down that, two things. One, initial pricing model. We're doing a revenue share model, lowers the adoption rate risk for Medicaid, which doesn't have the upfront capital for that, which is fine. It puts the risk on the right person, which is us. But two is really the end-to-end operations aspect of it. We are the only ones that we've seen in market right now where we can send a PHQ-9 prior to the visit, surface those results to the physician in the visit, and then schedule the follow-up for them afterwards in case of a positive test result. And we do that across all the quality measures of these managed care plans.
Very good. And how many contracts do you have, revenue contracts?
Right now, we actually did an early pivot into Medicaid earlier this year, and I'm working with these two clinics in Southern California right now.
Thank you very much.
Thanks, Neil and Cassie.
Thank you.
Thank you so much.
We'll press forward with Pix Health. Pix Health is a mobile solution that reduces loneliness and social isolation by connecting with your members outside of the traditional care setting. By providing critical and timely interventions and addressing social determinants of health, we take care of your members when they are most vulnerable, especially after a transition of care. Cindy Jordan, founder and CEO, will be the next presenter. Go ahead, Cindy.
Okay, great. Thank you for having me. My name is Cindy Jordan. I'm the CEO and co-founder of Pix Health, and we're a mobile technology solution tackling social isolation and loneliness. I know this is a topic for today. So we sell into Pix. We sell into primarily Medicaid and Medicaid care payers. And we launched in 2018, and we have about 14 health plan customers right now, and that includes 3 of the 5 top payers in the country. We've onboarded well over 7,000 Medicaid members, and we've raised $7.5 million to date. So one of the questions earlier from the presentation was, is loneliness going to be a problem before COVID? I mean, after COVID? And this slide articulates that it was before COVID. So as you can see up in the right-hand corner there was a Becker's Hospital review that found that 80 patients accounted for 5,000 ED visits in 1 year, an estimated 14 million in costs. And when they went back and researched it, loneliness was the #1 factor for these ED visits. So I like to talk about the problem globally, but let's bring it down to the perspective of one Medicaid member. Meet Janet. Janet has a healthcare event. And despite that best-in-class care, which is what you see there on that line, she ends up back in the hospital. Well, why is that? So I'm a huge Stranger Things fan, and this is what we call Janet's upside down, her alternate reality. So when she had her event, she didn't want to burden friends. She became isolated. She lost her job as a substitute teacher. She's depressed. She doesn't have enough money for food. She stops taking her medicine. She ends up back in the hospital. This is the 90% of healthcare that happens outside the traditional care setting, and this is what Pix addresses. So how do we do it? The first tenet is our intentional delivery. What I mean by that is that we work with our healthcare partners to get a daily census of any of their members that are going through a transition of care. ED discharge, inpatient, SNF, a recent behavioral health diagnosis, and then we use our compassionate call center to put them onto the platform. So when we get someone on the phone, we onboard someone 67% of the time. What's our second tenet? That's building trust. In my personal opinion, the healthcare technology is very greedy. We tend to take data from people and move it from one place to the other, but we're not solving a pervasive pain point for the end user. So we do that through our empathetic, super funny, he's kind of the antithesis of healthcare technology, Pixar, our chatbot. And he uses humor and sentiment, and he really just checks in with Janet every single day and becomes a good friend to Janet, a companion. Once we have Janet's trust, that's when we introduce things like evidence-based screening. So we test for the UCLA loneliness, PHQ, the GAD, and social determinants of health. So the third tenet is what I like to call,
We just have a minute left. That's what I said.
Oh, okay. The peanut butter and chocolate. So it's great to have a piece of technology, but what happens when members are really in need? You have to have human beings reach out to them. So we have, again, back to that compassionate call center, we call them all our Andes. It's a peer model for loneliness. We provide connection and connectivity. We become the conduit to the health plan and their care team. So does it actually work? One of our health plans conducted a case study, and they used 1,100 Pix members. This was conducted outside of us. They used a propensity score matching technique and used 10 controls to match for each Pix member. They matched on these attributes. This is important, but because it created a statistically valid study. And what they found was that the Pix Health users over a 6-month period of time saved on average each user $5,000. And that was primarily in ED visit reduction and inpatient stay reduction. And as you can see, the p-value is 0.001, which makes it statistically significant. And I think I'm at 4.
You are. Thank you very much, Cindy.
Sure.
We'll go to Ian first, then to Rob, and then to Brendan.
Okay.
Cindy, thank you so much. That was a great presentation. Can you, so in addition to Bravo Health, you have shown, can you talk about who are your other customers and just where you are from is it do you have an MSA signed with your customers, and how do you roll it out across the different states?
Yeah, so I have 3 national scopes of work with Medicaid payers, and I'm not allowed to use their name without their disclosure. So I have 4 national payers, right? 3 of them are in the top 5, so they're exactly who you think they are. And then the other 11 contracts are regionals. We do have one ACO that goes completely at risk for Medicare Advantage, and so we take on their high risk population. So generally, it's a payer sell, but for me and for my company, having gone through the national scopes of work, having to do the IT deep dives, we're 3 months away from being high trust certified. I now have like national run room. I can sell into other markets with just a scope of work signed, so 2 pages.
Got it. And for many of these health plans, when they use Pix, is it augmenting their existing case management, care management team, or is it more of a entirely outsourced to you guys in those markets?
Yeah, no, we're definitely not care management. A clinician does run the department, but here's what we do. If you think about care managers, they have to practice to their license, right? So they have a bunch of KPIs. They have to make literally like 30 phone calls a week. They've got to get blood pressure and this and that, all these clinical kind of indicators. We do exactly the opposite. So when someone says they're lonely, or they're testing very poorly inside our platform around sentiment, or they score badly on the PHQ, we'll reach out to them with one of our Andes and figure out what's going on. So let's just say they're just lonely. Well, then we'll put them on a program where we'll become a companion to them until they get themselves back to a place where they're, doing well. Let's say they need a DME. This just happened last week. A guy was very depressed because he fell and his chair got damaged. And so what we do is we talked to him, figured out what was going on, turned that referral over the plan, and in 10 days he had a new mobile chair. So we kind of do what the care managers probably don't have time to do. But the reason it works really is because they trust the robot. Like, the interactions with the robot are in the hundreds of thousands. People use it all day, every day, and they give up this information.
Got it. Thank you.
Mm-hmm.
We'll go to Rob next.
Cindy, great presentation, and I like the background and the the subliminal pot of gold at the end of the rainbow there.
Yes.
That's excellent. Well, you're a more mature company than some of the others we've discussed, so it's fair to ask you about the nature of your of churn within your contracts, people renewing, people canceling. Can you address that, please?
Yeah, 100% renewal rate. And here's the great part. Of the 14 contracts that I've started in Medicaid, I've upsold 5 of them into Medicare Advantage or self-insured. So what's great is that kind of when we get in, then there's this natural sale to keep moving on. Because our case study is so rock solid and we didn't conduct it, we're starting to do some risk model in Medicare Advantage, and that's going really well because, we have an entire data science team. I can tell you exactly, if I put 100 people on, I can tell you exactly how much money I'm going to save in 60 days, 6 months, and a year. And so I think that's helping us quite a bit in the MA space in particular.
And how regional are you, or you consider yourself national and kind of broadly national?
Yeah, no, we're literally all over the country.
You are all over the country. How many employees do you have?
42.
42.
42 too many. Nobody told me how unfun it is when it gets to this point.
Need to get a robot to manage them.
Oh man, I am just like, oh my gosh, I need an HR person. I need all these things, so.
Very good. Well, thank you very much.
Yep, you bet.
Hey, Cindy. Good to see you again. I think we spoke about 12 months ago, back in November, December.
Okay.
Yeah, but anyway, first, 14 contracts in 2 years is incredible. So congratulations on that. And I have two questions for you. One, just to get a better understanding of the actual platform. When I'm trying to parse out, what percent is call center / care team versus purely automation, what is the mix there? And if you can, and again, I know this is a recorded presentation, so I don't want to get at too sensitive of information, but understanding gross margins would be helpful in breaking that down.
Yeah. So when we contract, I'm very clear about the fact that since we're focusing on transitions of care and really high risk, high spend members, we probably touch about 20% of a population, although we allow the plan to market it to whomever they want, right? So the high touch is really on the front end, getting people on, and then you'll see that it's basically a 60-40 split between them using Pixr to self-manage and 40% of whom we actually reach out to if they score very high on UCLA loneliness or PHQ or that kind of thing. So the tech does a big lift once we get them on. Getting them on is the hard part, right? But when we focus on transitions, our conversion rates are very good because people, look, it's not rock science, right? Like you've just had a healthcare event. You're scared, you're anxious, you're depressed. You may or may not have shared it with your family. It is the time when loneliness has the propensity to affect their health outcomes, right? And then what was the other question you asked me that I might not be able to? My margins are sub 80 over 70. So I'll leave it there. Yeah, the margins are great.
Excellent.
Yeah.
So my second question, unrelated, but out of curiosity, when we're thinking about the imminent CMS budget cuts that are going to plague us all, what's your view on that as far as how it might affect your contract values? How you're addressing it, any feedback from health plan clients of yours? What's going on there?
Well, I think the fact that we're really poised to go into risk now that I feel super comfortable around the data will help us, right? So if you're going to get a budget cut, you don't want to do a PMPM model or go after like a SaaS model that's going to come out of your admin budget. You want to partner with a plan that actually is going to help you increase your margin. And, when we first started this 2 years ago, it took convincing to convince people that SDOH and loneliness are so intertwined that you have to treat them both together. That's over. Now every executive I talk to has actually experienced loneliness or isolation. And so it gets us over that conversation quickly. So I think the way around the CMS cuts is going to be by going at risk.
Agreed. Yeah, that's great. Thank you.
Yeah, sure.
Thanks very much, Cindy.
Thank you.
And next up is Phox Health. We've had a plethora of companies that start with a P and ends with an H in this pitch contest. So next up is Phox Health. Phox Health's software-based platform connects pharmacies, virtual practices, and health systems to 2-hour prescription delivery nationwide. Amit Gir, co-founder and CEO, will be speaking next. Go ahead, Amit.
Hi, everyone. Thanks for the opportunity to talk with you all. My name is Amit Gir. I'm a background biomedical engineer from Tulane University, right here in New Orleans. I'm the co-founder and CEO of Phox Health, and up until recently, I was a practicing hospitalist physician, frontline physician, up until early this month, and I just finished an 8-day stint rounding frontline yesterday. So excuse me for any misspeaking. So what is Phox Health? We are a software platform that connects independent pharmacies and even health system pharmacies with medical couriers in order to pull off, coordinate, and provide a 2-hour prescription delivery to patients nationwide. And with this simple concept of prescription delivery, we're able to solve a lot. We're able to solve prescription abandonment, a large reason why patients are non-adherent to their medications. With one single solution of delivery, we're able to treat a wide range of ages, socioeconomic groups, and disabilities and abilities. We're able to help the independent pharmacies and health system pharmacies compete against the big chain pharmacies in the country. And finally, as telehealth has skyrocketed around the country and everyone is clamored to diagnose on demand, no one has been able to solve how to treat on demand at scale until now. So how does Phox Health work? So a patient just had a provider visit virtually. The provider's practice pings our system and we match that patient to a single pharmacy within our network based on time of day, location, and even sometimes particular medication. Once the match is made, we help coordinate prescription delivery to that patient in as little as 2 hours. We have two different types of customers, small and medium type telehealth practices, and most recently entire health systems. One of the telehealth practices we're proud of is one that does televisits for flight crew. So these are pilots and flight attendants staying in hotels around the country. When they first reached out to us, they asked if we could deliver to 10 hotels around the California area where we're based. They needed all prescriptions delivered within 3 hours because of the sensitivity of their schedule, and they needed a way to scale. In the last 3.5 years, we now delivered to over 147 hotels nationwide, all still within 3 hours and proven scale. And at one point, we even delivered a prescription within 14 minutes to a hotel in Boston. Now, how did we do that? Is it because we had the best pharmacy and the best couriers? I would argue it was the tight integration of our platform connecting the provider, the pharmacy, and the medical courier in those locations in order to pull this off and do it at scale. And now we work with health systems, same technology and coordination to them. And we pitched them that we can create an Amazon Prime-like experience, but even go beyond that, because 2-day delivery for me is way too slow. Even same day is slow. We're now able to offer on average 2-hour prescription delivery from each of these pharmacy locations at scale. And our most recent, our previous partner was with Ochsner last year. We coordinated delivery across Southeast Louisiana, integrated their 12 pharmacies, launched within 28 days of signing our contract. And we have a fully automated system where the pharmacy only has to ping us within 2 seconds and the prescription is sent off and the delivery request is sent off for pickup. We helped them through the COVID-19 pandemic as we saw a tremendous surge in deliveries as their entire population of prescriptions was shifted to our platform, and we handled everyone without a hiccup. Most recently, we signed MultiCare in Tacoma, Washington. We'll be providing prescription deliveries from patients visiting their 30+ urgent cares. We've expanded our delivery windows to 14 hours a day. Within 3 days of the specialty pharmacy using our platform, they paid for our entire monthly bill. And now we're able to precisely coordinate their hospital at home program with IV medications arriving the moment the provider gets to the patient's home so they can provide coordinated, timely care. So in summary, we've scaled from independent pharmacies to entire health systems. We've gone across the entire spectrum of helping a wide range of patients and abilities and ages. We've scaled from same day to 2-hour prescription delivery nationwide, and we've been able to scale from any location based on demand alone.
Time's up.
That is Phox Health. Thank you.
That's great. We're going to go to Rob first, then to Brandon and Ian.
A very interesting business model. I need to start my video, I guess. Hang on. There we go. I thought I had. Excuse me. Very interesting business model. I appreciate the presentation. Can you tell me what year you were founded?
2016.
2016. And I guess I need to understand a little bit better how the cash flows here. You talked about contracts, but who pays you, and can you explain how the cash flows here a little bit better?
Yeah, so we partner directly with health systems. They pay us to implement the software by integrating our software with the pharmacy. We first do a low-touch method by providing a custom-built iPad app for the pharmacy staff to scan prescription labels, and then we integrate with their EMR later at a later date. So they pay us for that integration. They pay us monthly fees to use the software, and then they pay us a processing fee for every delivery that's done. The actual delivery cost is a pass-through cost from our courier partner in that location. So the delivery fees are transparent, and we operate at a 98% profit margin on our delivery fees. So that's sort of our blade to the Gillette razor model.
Well, I think 98% is a pretty good margin. I don't know that we're going to beat that today with anybody else. I guess the question that I would have is, it sounds very labor intensive, making a lot of interactions and everything. How many employees do you have, or is all this just subcontracted out?
We have, as of August, we have two full-time employees. I was practicing full-time inpatient care up until August when the company signed a second health system contract. I left, We launched with Multicare last month while I was still working full time, and we were able to pull off the complete launch with just myself and my co-founder 9,000 miles away in Bangalore. We're an extremely lean team. Yes, it's subcontracted, the actual delivery part, but it's our software that connects all these disparate groups together that we're able to pull this off with an extremely lean team. We just hired a third intern a few days ago.
Thank you.
You're welcome. Thanks, Rob.
We'll go to Brandon.
What was I going to ask? Yeah, so health systems. Why did you choose health systems? Given, I mean, coming from one myself, the sales cycles are ridiculous, and they can be very, very complex as far as who the calling points are and where the incentives are. So first, why did you choose health systems as your client, your paying customer? And two, how would you segment the health system customer market? And to you as a business, what's the most attractive health system segment or profile?
Yeah, great question. We initially started by working with small and medium-sized telehealth practices to basically copy and paste what we were doing for that flight crew virtual practice. We were approached by Ochsner in 2018, and like Sir Richard Branson says, never say no to an opportunity. So we said we could pull it off. 13 months later, we completed the contract with them. And once we signed a health system, I realized I think they're the best customers because they have existing pharmacies that are underutilized. They have patients that they're trying to keep within their ecosystems as other digital pharmacies are trying to take over. Amazon Pharmacy just announced yesterday. And so they have these existing brick and mortar pharmacies. They have these existing urgent cares. And now everyone has a virtual care platform. So we focus on health systems of a holy trinity that are health systems, that have virtual care, which is now everyone, and then have at least one of their own retail pharmacies that are 90% underutilized at this point, as a way to outcompete even Teladoc can't provide what we do with Ochsner and Multicare today, which is on-demand treatments after that visit.
Wonderful. Yeah, that makes sense, and I largely agree. With are you, just so I understand so Rob, I know asked about the flow of funds, but I want to ask about flow of medications. Are you actually bearing drug inventory and reselling, or are you purely a logistics control center, so to speak?
Yeah, it's a technology logistics play. So once the prescription's paid for and dispensed, they ping our system to come have it picked up from that pharmacy location. And then that's exactly what we do. So the next phase that we're going to be doing with Multicare is actually identifying the drug that we're delivering. So we can start mapping out where these drugs are being delivered, and we can provide in real time, as say Tamiflu is being used in certain zip codes. If we can map out and discover where flu hotspots are occurring, just by virtue of this concept of geopharmacy, finally mapping out in real time where medications are going at the moment they're prescribed.
And what's so, last question, what's so special about the logistic capabilities that you have? I mean, I know you talk about 2-hour delivery, so that's one aspect. But as far as other kind of willingness to pay drivers, if you will, for a health system as the paying customer, what's the kind of the value prop drivers that enable you to win these contracts with health systems?
Yeah, so the actual delivery, I'll be honest, there's nothing special about that. When we present ourselves to health systems, we say if the courier that we use in your area doesn't work out on day 10, we'll switch them out immediately. But what won't change is the workflow that we built for your pharmacies, which is minimal. And we can keep changing, adding, and expanding couriers without any additional training to your pharmacy staff or any changes to integration. Because if a courier doesn't work for a health system, so the example with Multicare with FedEx, they were charging $30. They had to go to FedEx's website. They had to manually enter in all this information. They never got patient feedback, and all they got was Excel spreadsheets and CSV files of their audits of their deliveries. Day one that we started with them, we were providing them live patient feedback with the ratings and comments. We were able to provide them real-time tracking. We were able to send out branded text messages and emails to the patients. So it was a completely different delivery experience. So even if we plug FedEx back into our system, the patients would still be getting that amazing experience, and the health systems would be able to tap in immediately as to what's going on. So basically, we out-technologied FedEx.
Got it. Thank you.
Great question.
Hey, Amit. Good seeing you again. Hey.
You too.
So I I don't have many questions, but maybe can you talk about who are your direct competitors and do you see any competitions coming up?
Yeah, so one of our direct competitors is a company called ScriptDrop. Their focus, from what I can tell, has been mainly on grocery store pharmacies. Similar concept that those pharmacies are underutilized and they needed a logistics way to deliver. But what's unlike ScriptDrop and another competitor, NimbleRx, so the independent pharmacies we work with, I didn't get to touch with that on that point too much. We provide almost a $0 lead channel to send new business. So as we're matching new patients to local pharmacies around the country, we're recommending that providers send that e-prescription to that independent pharmacy, and then we help, facilitate the delivery after that. So no other system out there right now is actually supporting these independent pharmacies with new business. Once we reach a certain threshold of traffic that we're sending these independent pharmacies, they pay a set subscription fee for our services, and we're careful not to do it by prescription due to potential Stark laws and self-referral issues. We're the only platform that can provide new business and protect new business for health systems.
Got it, great. And maybe, I know every health system is different, but remind us what do you think it will be the total account size for one health system like MultiCare at steady state?
Sure. So MultiCare was losing about 500,000 prescriptions it was writing to outside pharmacies just from its urgent care centers. The goal is to recapture every single one of those internally and day one drive pharmacy revenue that they were losing by virtue of this delivery platform. Remember, the reason everyone signed up for Amazon Prime was not because of the amount of products Amazon had, it was because of delivery. So we believe delivery is going to be the first step for truly providing convenient care and a way to protect the ecosystem of patients for health systems.
Got it, thanks.
Thanks very much, Amit.
Thank you. Thanks, everyone.
And we'll move on to our last company, Dina. Dina powers the future of home-based care. They are an AI-powered care coordination platform that can activate multiple home-based service providers, engage patients directly, and plug into remote monitoring devices. The platform creates a virtual experience for the entire healthcare team so they can communicate with each other and help patients and families stay connected, even though they may not be physically under the same roof. Dina helps professional and family caregivers capture rich data from the home using artificial intelligence to recommend evidence-based non-medical interventions. Ashish Shah, CEO, will be our final presenter. Go ahead, Ashish.
Thank you. Before I begin, just congratulations to all of my co-presenters on building wonderful businesses and great presentations. So as mentioned, I'm Ashish. I'm the CEO and co-founder of Dina. We're a healthcare technology business that was founded in 2015. The majority of our team helped build the market leader for healthcare interoperability that was ultimately transitioned to Aetna. I was a CTO and head of product there. And it was really there where the Dina journey began. 6 months after that transaction, my father suddenly passed away, which sort of shined a really bright light on the work that needed to be done in the industry. My father was seen by a number of in-home caregivers in and out of senior care centers. And after he passed, we spent time with them. And we found that there was they had an overwhelming insight around his decline, yet no real way to share that insight in a way that would ultimately affect his outcome. As my partner and I sort of dug into the business, we found that clearly 10,000 people are turning 65 years old a day. Overwhelming majority of folks want to age in home. But I think with COVID now, we're seeing a number of health systems really race to build at-home care delivery models in a way to manage total cost of care, as well as capture new revenue when people are not coming into their facilities, as well as work directly with health plans to activate at-home care models in a way that delights patients, drives member acquisition, but also manages the total cost of care. This is something that when we started the business, there was a lot of head nods around it, but now if you look at it, you're seeing massive acceleration in at-home care models. Clearly the pandemic is playing a big role into it. We're seeing reimbursement change, but hospitals are aggressively forming joint ventures with home-based provider organizations. And you're seeing health plans and retailers really invest heavily in at-home care. Our perspective, so what Dina does is we provide a technology platform for hospitals and healthcare providers to really increase the number of healthy days at home. Really a proxy for managing total cost of care, so managing the cost of it, but also boosting outcomes in a way that drive non-medical interventions into that environment and keep those members or those patients sort of within their preferred ecosystems. Our model of care at a very high level is something that we internally refer to as care traffic control. And we really do three things really well for hospitals as well as health plans. The first is coordinating a basket of home-based services that are typically offered within the four walls of a facility. So think about skilled nursing paired with non-medical home care or personal aid support, coordinated with durable medical equipment, and perhaps a physician visit. All of that is, you can arrange all of that individually on a referral basis, but to coordinate all of that together as if the experience was being delivered together under the same roof is easier said than done. So core part of our value proposition. The second thing that we do is we activate an asset light or a lightweight remote patient monitoring experience that allows us to maintain a relationship with that individual, even though they may not be physically seen by someone or in a facility. And then the third thing that we do is we bring back interesting population level insights, specifically that are home-based. Who's struggling with social well-being, activities of daily living, health and safety, and readying for transition. The net of it here is that we really drive management by exception. We have a number of great clients on the roster, but wanted to talk to you specifically about Jefferson. The work that we did with them around COVID allowed us to manage 2,200 patients, facilitate 24,000 digital conversations, and drive $280K worth of savings in a 90-day period, and boost PCP visits by 74%, all by facilitating a smarter coordination with the home. Our business model at the end of the day, and we can touch on this in the Q&A, is to really increase visibility into the home, modernize that as a professional care setting, and use it to drive great outcomes, both clinical and financial. And as I said, the train's left the station on this. Clearly, virtual care is here to stay, and so is in-home care.
Great, your time is up. Let's go first to Brandon, then to Ian, and then to Robert.
Thank you. Yeah, this is a big topic at our fund and our health system. With I wanted to ask you to get some clarity on the model. Is there a brick and mortar component, or is it all software and then mobile care in the home?
Yes, today it's largely connecting. And so really think about upgrading traditional care or population health management teams sitting in a call center or in a facility, connected with in-home care providers. We do not employ them. We really broker them at the end of the day. So even if you go into the market, the most dominant home-based provider does not have dominant market share. Or if they do, it's around one specific service like Medicare reimbursed home health, but not non-medical home care, hospice, palliative, or the ability to do home-based med management or physician house calls.
And so is this, you bring up home care, is this home health or home care that you're playing in? It sounds like both, maybe?
Yeah, both. It's really home-based care, and that could range from clinical to non-medical all the way through.
Sure. Do you have any case studies that you're able to share about, the ROI for these partners?
Yeah, absolutely. So I'll use Jefferson Health, and I apologize for rushing through the presentation, but so Jefferson Health has been a partner of ours for a long time. Dr. Klasko is a big advocate of healthcare with no address. We've executed on two aspects of the vision that I outlined. The first is if you look at something like an at-risk model around bundle payments, being able to coordinate post-acute home and additional services to manage the total cost of care. Within the first 9 months of our arrangement, when you looked at CHF and sepsis, we were able to drive savings north of $1.7 million around a population that had the exact account patients escapes me, but it was a fairly rapid ROI in a short period of time. And then the second piece is specific around COVID. So really activating a home-based virtual assistant to coordinate telehealth visits or other sorts of check-ins was able to generate close to $300,000 worth of operational savings, not to mention new revenue capture and additional ROI measures. All of that happened within a 9-day period.
Well, thank you.
Yep.
Ashish, great presentation and nice to meet you. Can you talk about the payer use case and have you had any existing payer contracts and how do you arrange, how do you price your solutions?
Yeah, so let me start with the latter part of the question first. So our business model today is we're a subscription-based platform. So, and we can size that in a number of different ways. We can look at obviously a PMPM component to it, and that works both for providers as well as health plans. But we also have a per site subscription scaler. So based on the volume and the type of care setting you are, we can activate a subscription. Our goal is to bring as many of these home-based providers online as quickly as possible and get them connected back to hospitals and plans. Now our model will evolve. And as we increase the number of homes that we're connected to, bring back more and more data points from the home, we think that will put us in a unique position with the visibility it'll create to actually convene and broker value-based contracts for home-based providers in a way that actually compensates them for being a more engaged partner. To your first question in terms of our contracts to date, so we recently closed Health First, which is a top managed Medicaid plan in New York City. They're a big partner. We're in the process of actually activating and rolling out our solution in that market. We're quite excited about that because our largest footprint and penetration to date has been in Greater Philadelphia around Jefferson Health and Beata Home Healthcare, et cetera. We also have a proxy for our health plan contract is a fairly large relationship with CareCentrix that manages 26 million lives across the country and serves an overwhelming number of health plans. And so we are their digital enablement platform. So a couple of early data points in terms of health plan traction, but I should mention, we just launched our health plan to home model earlier this year, right before COVID.
Got it. Thank you. Good timing.
Thank you.
Let's go to Robert.
Okay, I guess I'm the last of the day here, huh? The excellent presentation. Thank you very much for hitting your timing marks also. What year were you founded?
So we founded the business in 2015, and we quietly bootstrapped the business until we raised our first outside round in 2017. And
you've raised several rounds since then?
One formal institutional round, and we're in the process of one right now that we'll be able to publicly share soon.
You talked about you were able to drive PCP visits by 75%.
Yeah,
that's substantial, and I was very impressed to hear that. When you started talking, you talked about basically your business is to keep people at home and to reduce the cost of hospital admissions, et cetera. The 75% of the PCP visits that you're driving, were those all telemedicine?
No, there was a mixed model, and we're still working through that. But that data is very specific to, if you look at what happened in April in the Philadelphia market and the number of COVID cases in particular, the 30-day PCP visit number was actually north of 84%, so it was very, very high. And then the 90-day PCP visit, or the first 30 days was 74%, the 90-day was up to 84%. So it was a mix of telehealth as well as some in-person. And it's gone up and down, but that particular data point was very, very strong. And so I think our technology is unlocking a lot of value by brokering access to care in the right setting, which could coordinate with your home-based provider or your virtual care provider.
You also quoted some statistics on how much money you would save, return on investment, et cetera. But one of the other ways to look at how successful your business model is to ask about customer churn and the different customers who renew or don't renew, et cetera. So could you speak to that and your experience over the 5 years since you've been in business?
Yeah, so today we have north of 60 contracts, which ranges across large enterprises or small home care settings. And we've seen less than 3 to 4% churn in those contracts. And so we've retained a majority of them. We think that by investing in customer success, maturing the product, will start to drive that down lower.
Well, it's still pretty low to begin with. Very good. I'm impressed. Thank you very much. I think you've answered all my questions.
Wonderful. Thank you for the time. Sorry for the rush presentation.
Thanks very much, Ashish. And thanks to all the startups and the presenters that came and participated at this conference. Now it's time to start the online poll for an audience favorite. So let's start the poll. As we tabulate the results and share with you, I wanted to let you know that as soon as we declare the winner, the networking session will formally begin. Laura will put the link to our networking platform. We use a fun platform called Remo. So I encourage all of you who are still waiting here to join us on Remo, where we'll also share the judges winner. So Walter, if we are ready to share the audience choice right now. And there we go. I think Dina is the audience choice. Ashish, if you'd like to say a few words.
Not really prepared other than thank you for the opportunity and congratulations to all of the co-presenters today. Really neat, interesting businesses. And this is a community and a journey. I'm just honored to be a part of it. Thanks for the opportunity on behalf of the entire team. Thank you. Congrats
to you again, Ashish and your team. All of us, let's continue the conversation at our networking event and hope to see all of you there.